Welcome to week two pathophysiology of diabetes and the case discussions around it. My name is Dr. Vinay. I'm one of the consultants at University Hospital of Wales in Cardiff. Our first case is a 56-year-old female with chronic obstructive airway disease, presents with polyuria and vaginal candidiasis. She has had recurrent chest infections and has received multiple courses of antibiotics and steroids. She is now on inhaled salbutamol and inhaled steroids. On examination, her BMI is 23 kilograms per meter square and her abdominal circumference is 76 centimeters. Her random blood glucose is 11.9 millimoles per liter. So, what is the most likely diagnosis? We know that this lady has symptoms suggestive of polyuria and polydipsia, and also has a random blood glucose which is higher than the cutoff value of 11.1 millimoles. So, the likely diagnosis on the background of her history of steroid use would be secondary diabetes. Which tests, if necessary, would you perform next to confirm the diagnosis? Would it be fasting plasma glucose or oral glucose tolerance test, repeat HbA1c, random blood glucose, or you would not do any test at all? The right answer is probably no further test needed because she has got osmotic symptoms and there is an evidence of raised blood glucose which was tested randomly. Which of the following medications is associated with the development of secondary diabetes? We know that there are certain medications which increase the propensity to develop type 2 diabetes, and one of them is olanzapine from this list. The explanation for this stem of question would be that steroid-induced diabetes is seen with chronic use of steroids and is directly proportional to daily dose of steroids. The mechanism of steroid-induced diabetes can be due to beta cell dysfunction and insulin resistance in the peripheral tissues. There is usually postprandial hyperglycemia in these situations, hence performing a fasting plasma glucose may mislead and at some times may actually prevent us from getting to the right diagnosis. So it is important, if you want to do a test, then it should be an oral glucose tolerance test or an HbA1c, or in the combination of the random blood glucose more than 11.1 and osmotic symptoms, you can make a diagnosis of steroid-induced diabetes. So this is the reference for further reading, and some of the discussion points which you can do is to read around what is secondary diabetes, what are the mechanisms of hyperglycemia in this condition, what is stress hyperglycemia, and how do you differentiate it from other secondary cause of raised blood glucose, discuss the pharmacological agents that can cause hyperglycemia and how to manage this particular situation. So we go on to our next case cluster, which is a 32-year-old male who presents with 3-month history of weight loss and polyuria with polydipsia. He has a history of excessive use of alcohol and drinks 35 units weekly, which is far more than what is recommended. He has been admitted to hospital with recurrent abdominal pains. Both his parents are diagnosed with history of type 2 diabetes and are now managed on insulin. On examination, he has features of chronic liver disease, or actually liver failure, as he has mild ascites, pyotonia, and pulmonary edema. His blood pressure is 130 over 80 mmHg and his BMI is 25 kilograms per meter square. We have some blood test results for this gentleman, and his hemoglobin appears to be stable, as is his renal function test, but his HbA1c is above the cutoff for making a diagnosis. So, what is the likely cause of his diabetes? Is it LADA, which is late onset autoimmune disease? Or is it maturity onset diabetes in young, secondary diabetes, type 1 diabetes, or type 2 diabetes? Given the history and his presentation, history of chronic abdominal pains associated with liver failure all point towards possible pancreatic damage secondary to his alcohol abuse. So the possible diagnosis here is secondary diabetes. How do you diagnose the pancreatic failure? Which of the following is the next step in evaluation? Would you like to do an anti-GAD antibodies on him, CT abdomen, a fecal elastase, HNF alpha 1 mutation, or glucokinase mutation? We know the diagnosis is secondary diabetes due to the pancreatic damage, and we would like to know what is the extent of the damage or if there is anything else causing a pancreatic insufficiency. So the most prudent approach would be to conduct a CT abdomen and see if there are any changes in the pancreas. Pancreas has two functions, an exocrine function and an endocrine function. And if we want to ensure that there is no endocrine dysfunction, we're going to test for his blood glucose. And for looking into his exocrine function, the best test would be, you should choose from one of the following. Is it elevated serum amylase, blood glucose, fecal elastase, raised triglycerides, or undetectable C-peptide levels? We know that the pancreas produces a lot of peptidase enzymes and is essential for the digestion. And testing the fecal elastase would be an appropriate choice in this situation to assess for exocrine function. Pancreatic exocrine dysfunction associated with chronic pancreatitis and eventually endocrine dysfunction can ensue. It is important to rule out other organic causes like malignancy in the right clinical context. We have some reference for you for further reading and to discuss further things like what is pancreatogenic diabetes, what is type 3C diabetes, what is its prevalence, what tests are performed and how do you evaluate such a scenario, and what are the different causes for pancreatogenic diabetes. Hope you enjoyed this case cluster. Thank you very much.